Little backdrop to it, which I thought I'll discuss with you. That many years back, some people found that people who have got retinal scarring because of myopia or because of any other disease did not develop diabetic retinopathy in spite of having diabetes. And they started looking for reasons what happened, why it has happened that they do not develop retinopathy. And there was one gentleman, who was pioneer in in creating actual retinal burns for treatment of retina. And he is the first person who started using a xenon arc bulb, and before that he started using sunlight. They used to have heliostats which will focus at the sunlight and make burns on the retina. And Maya Shukroth, in fact, when I met him as a student in 1986, he had already become blind because of his macula getting damaged. During research, he damaged his own eye actually. So from there, people took a lead that maybe by creating retinal scarring, something was going to happen, and that is how retinal photocoagulation came into existence. First it came with xenon arc, and then later on with lasers. But that was not the most physiological treatment for diabetic retinopathy, and then they kept on doing research and finding out more and more reasons. And whatever research is taking place, one should not lose the perspective of looking at a patient in totality. Like eye surgeons must know a little bit about diabetes, and all the internists, physicians and endocrinologists, they must know a little bit about diabetic retinopathy, because we are going to manage our patients together. So it is a teamwork which helps in total management of a patient. Diabetic eye disease is a very wide spectrum because diabetes affects each and every part of eye. But we will focus mainly on retina, and also that what is new that is happening. Gestational diabetes, which is recognized as a separate entity, and also some genetic defects in beta cell functions and insulin action, and disease of exocrine pancreas can also lead to diabetes, especially cystic fibrosis. And if some of you are interested in the DIMOD, which is diabetes insipidus, diabetes mellitus, optic atrophy and deafness together, there is a special syndrome. What is the criteria for diagnosis of diabetes? We have also given you in the literature that is in your kit, that people who have got classical signs of hyperglycemia, it is still recognized by ADA as a classical diagnostic criteria, besides impaired glucose, fasting glucose and oral glucose tolerance test, in which 75 grams of glucose load is given, and after 2 hours the blood glucose levels are between 140 and 199. Why I have picked up ADA is because most of the research which has gone into diabetic retinopathy as well has been conducted in America only. Now the carry-home message for people is that American Diabetic Association recommends a tight glycemic control, and tight glycemic control means that fasting less than 100, all readings below 180 in 24-hour euglycemia, and most important is glycosylated hemoglobin less than 6.5%, and tight control of blood pressure depending upon age of the patient and sex. 130/80 is absolute is the target. So all these things have become target based now, and those targets must be achieved. And most important is that patient education and self-management training has to become a part of total management, which is being encouraged. And also a patient should be empowered when a patient should seek specialized medical help. That should be that right, and that decision is going to be with the patient. Why I have added all this is because a patient must be looked at in totality. Holistic management, Dr. Verma, we were talking in the morning. Holistic management means that even an eye surgeon should ask all these questions and look at the glycemic control of the patient. Regarding diabetic retinopathy, when we look at epidemiology, we find that 6% to 34% of patients have signs of retinopathy at the time of diagnosis of the disease itself, which means that it is imperative that any diabetic patient that you find out, that you discover in your practice, should be sent for a complete eye examination immediately. The reason is that this figure of 66% to 34% is coming from USA. So it is likely that our percentage is going to be higher. And I can only share this experience with you that there are many patients who for the first time come to an ophthalmologist and they are found to have maculopathy or advanced diabetic retinopathy, and it is a very late stage already. So it's both ways, that even eye surgeons should send back patients to internists. It is clearly known that the rate generally increases with age and passage of time since diagnosis. If you are diagnosing a diabetic at 55 years of age and you are diagnosing a diabetic at 45 years of age, the chances are that the older patient is more likely to have diabetes. And time since diagnosis, more the time, greater are the chances. And not the same way for every type of diabetic, which means that people having type 1 diabetes will have a little delayed. They are in the younger age group, and those on maturity onset will develop it faster. Race and ethnicity are confounded by quality of care and social factors, which means that people have this impression that diabetic retinopathy and complications of diabetes are probably more in developing countries, which may not be genetically and racially acceptable completely, because the level of care and the social care which are available are also different. So it's not only the race and ethnicity, but also the type of care which will determine whether complications are more in a society or not. Now, what are the comorbidities? Comorbidities like hypertension, renal disease, dyslipidemia, elevated body mass index, all these factors will increase the risk of retinopathy, and that is why the type 2 diabetes, generally we'll call it as a metabolic syndrome. Diabetes itself is a syndrome, is recognized as a syndrome now, but in type 2 diabetes, people who are fat, who are obese, who have got dyslipidemia, there is a metabolic syndrome and it needs to be addressed in totality. And all these things are going to affect retinopathy as well, which means the simple derivation is that patient's blood pressure must be kept in check, dyslipidemia must be addressed, and patient must be encouraged to reduce any discrepancy in BMI. Now this is a little interesting slide because we are going to derive some major conclusions from this. First is that every major cell type in retina is affected. I can just add that every major cell type in eye is affected. Initially there is more blood which goes to the retina. There is increase in fact, in the initial years we used to have special Dopplers to measure the total blood flow which was coming to the retina. There is deregulation of turnover, of cell turnover. Now this is a very interesting thing, because what happens is that when you have capillaries coming, you have pericytes and you have got endothelial cells. Now the now endothelial cells, they multiply much faster. So their deregulation means that their multiplication rate will get affected earlier than pericytes. So pericytes die a little later, but endothelial cells, they started showing changes much earlier, and that is the reason that capillary dropout starts. That is the basic, the lowermost damage which takes place. And apoptosis, which is mediated by tumor necrosis factor alpha and oxidative stress. Now apoptosis is a pathological term which is being used very often these days. Apoptosis means programmed cell death. I can in simpler will tell you that if there are 100 cells, out of which 10 may die at 60 years of age, another 10 may die at 65, but the remaining cell, the tissue is alive. So it is programmed cell death within the tissue. It is a little different from necrosis, where there is cell death, but this is a programmed cell death where the histopathological pattern is different from necrosis. So necrosis and apoptosis, they are a little different in terms of the end pathology that you will see in the cells. Maybe next time we will add this material also. But apoptosis is something which which is happening and is leading to dropping of cells. Now there are hypoxia inducible factors. One, growth hormone, IGF-1, HGF, PDF. I will not go into the greater details of this, but angiopoietins, integrins, all these, what are these leading to? These are leading to formation of abnormal cells, abnormal angiopoietic activity. And at the same time, there are pro-inflammatory cytokines and chemokines which are being released. All these are, this research has happened at the molecular level. So you can imagine there are so many factors which are being created at the level of retina itself. And to make the matter worse, there is quelling of anti-angiogenic factors, which means that in life, at every level there is equilibrium. So this equilibrium towards maintenance of blood vessels is getting lost, whereas angiogenic factors are going up, but anti-angiogenic factors, they are going down. And this is where our intervention comes at molecular level. We are looking at molecules now. We are not looking at photocoagulation alone. We are not looking at creating scars alone. Can we modify these at the tissue level, all these factors, or not? We can, and that is how we are going to discuss in greater detail. There are cranial neuropathies which are associated with diabetes mellitus, third, fourth, and sixth. This is not fifth. Fifth is also gets affected. Sixth, cranial nerve palsies are seen, and pain in the microvascular ischemia, which is a very interesting thing. That vasa nervosa, they get affected. There are blood vessels which are supplying to the nerves. They get affected, and you get pains which are inexplicable, which people normally don't feel. Why is it that a diabetic has got a very severe headache? Why is it that a patient has got trigeminal neuralgia? Because trigeminal neuralgia nerve itself gets affected in diabetes. Facial nerve can get affected, and whenever you have these motor nerves, they getting affected in diabetes, they can cause pain. So a diabetic may complain of a pain while chewing, trigeminal symptoms, they will, and Wolfram syndrome is the same as I told you, diabetes insipidus, diabetes mellitus, optic nerve atrophy, and deafness. We have certain investigative tools which have come only recently into existence, and OCT and fluorescein angiography are two. Fluorescein angiography, most of the people know. OCT is optical coherence tomography, which is a late entry into it. But you can imagine it works on the same principle as ultrasound, where you send a wave inside, and when the reflectivity pattern is checked. So we have got in our clinic a spectral domain 3D OCT, which has got a resolution of as small as 5 nm. Whereas it is 100 times more sensitive than ultrasound. So you're checking things at molecular level, you're picking up things which are in preclinical stage also. We are using near infrared bandwidth 820 micron beam in it, and the interference pattern we analyze, we get an A scan, and we also have an interpolated B scan. And the same thing can be also used for anterior segment, studying the cornea with a wavelength which is slightly different. I'll just ask Dr. Lalit that he will just take you through a couple of OCT images which we have captured just for your orientation, and we have in your kit given you an actual picture as it appears on the OCT.
Actually